much for your service to the mental health world. And so I'm standing next to, I'm Tom Parker, by the way, standing next to Nicole Mori, who's a nurse practitioner in our research department when we opened Lindner Center of Hope with the support of McLean Hospital in Boston. They said, whatever you do research. And Dr. Susan McElroy came to us to be a researcher and hired us her team, and you're one of the team. So Lindner Center of Hope does research, as we just mentioned, right? And the research influences how we see the mental health world and how we see our patients, inpatient, outpatient, in our assessment programs. Will come in from all over the world to get clarity, and you guys help in that way so much. So I want to thank you personally for that. So it gives me great pleasure to introduce Nicole, and her presentation tonight is entitled Research. And let me read it here. I almost forgot it. So what has research ever done for us? What or you or anyone, right? So what is research? Could you tell us tonight? And we're so glad you're here. Thank you so much.
Can you guys hear me? All right. So as
So there you go. All right, that's good. See if that works now.
So as
There you go.
Tom has already mentioned, research has always been an integral part of what we do at the Lindner Center of Hope. Ever since the center opened back in 2008. Okay. So we are very fortunate to have a world-class expert in the field of psychiatry as our chief of research. Dr. McElroy is a very prolific author in the scientific literature with over 600 publications, including journal articles, scientific papers, reviews, and books. She has been recently recognized as one of the top women scientists in the U.S. And she is well known for her expertise in bipolar disorder, impulse control disorders, and eating disorders. Our associate chief of research is Dr. Francisca Romanava. Dr. Romanava is currently conducting research into novel targets for the treatment of major depression with his spinal stimulation study, and also looking into the role of the circadian system or body clock in obesity and binge eating disorder. We are a very small but very dedicated team comprised of study coordinators and study clinicians, which include Dr. Anna Georgieva, who is a well-known expert in the field of binge eating and other eating disorders, as well as a clinician. So at the Lindner Center, we conduct clinical research studies that's centered on the patient. Our aim is to increase understanding of mental health, mental illness, and find better ways of diagnosing and treating psychiatric illness. And overall, to improve the quality of life of those living with psychiatric illness. So let us begin with, we're going to begin with a patient vignette. Advancing the slides. So it seems like we're having a bit of a technical difficulty, but you have the slides at home. So we're going to begin with our case study. Lisa is a 43-year-old office administrator. She's married. She has 2 children. By all accounts, she appears to be a very accomplished professional, and she seems to lead a very fulfilling life. Lisa also has binge eating disorder, but she doesn't know it. Several times per week, Lisa feels intense urges to eat, even shortly after consuming a full meal. She feels tense and irritable, and these feelings don't go away until she eats whatever is at hand. It's usually snacks or sweets. She never intends to eat much, but usually she ends up eating the entire container of whatever she has in front of her. In her words, scarfing the whole box within minutes. She feels powerless to stop the urges, and she eats until she feels uncomfortably full. Lisa is bothered by frequent intrusive cravings and thoughts about food, which are sometimes intense enough that they interfere with her concentration at work. Binges are also followed by very intense feelings of guilt, shame, sadness, disgust, but she does not engage in purging. Lisa is very frustrated by her inability to control her binge eating. She has diabetes and knows that the binging is sabotaging her treatment for the diabetes. She has tried diets, but she finds that they actually make the symptoms of the binge eating worse. She blames herself for her lack of willpower, and she feels that there's something wrong with her and that it is beyond help. So Lisa is not an actual patient, but her experiences are something that is shared by other people with untreated mental illness. Psychiatric illness is not always obvious, and it can cause significant distress and disruption in all areas of life. It can affect your physical health, your performance at work, your social life, makes you feel hopeless and isolated. Psychiatric illnesses are also very common. About 50% of people will experience some sort of psychiatric problem at least one point in their lives. 1 out of every 6 people are currently taking a medication for a psychiatric symptom. It's like I brought,
It goes the other way for some, try to see if that'll get you to the slide.
All right. Thank you. So here are our learning objectives. In the course of the presentation, we will learn about how clinical research has attempted to address the needs of people with psychiatric illness by developing new treatments, establishing a scientific understanding of psychiatric illness, and lessening the stigma and increasing access to treatment. So this is an illustration by Willem Hogarth, an 18th century English painter. He was known for his portrayal of the darker sides of life in his day and age. This scene represents an institution called St. Mary's, Bethlehem, which was an insane asylum or institution that was established for housing and containing people with severe mental illness. This engraving gives you a glimpse in how society used to deal with severe mental illness prior to the development of psychiatry as a science. In this drawing, you can see a number of the inmates of the institution engaging in bizarre behavior. Some of them are restrained with chains and dressed in rags. And in the background, you can see 2 very well-dressed visitors looking on in curiosity. As we seen before, insane asylums were institutions for housing people with severe mental illness. Back then, mental illness was seen as a moral weakness, a sort of punishment for immorality or even sin. There were very limited means of addressing the behaviors that went on with severely ill patients. And the only means they had at their disposal were basically containing the patients and using restraints and a variety of very ineffective and risky treatments like bloodletting. Um, so asylums were a little bit more than prisons, and the living conditions were often appalling. This institution was known to have no windows and poor ventilation. So the conditions, as you may imagine, were pretty horrific. These institutions, the state asylums, dependent on donations for funding, and a way in which they raise funds was conducting tours with paying members of the public. These were billed as educational opportunities, but were in fact exploiting people with severe mental illness for entertainment. So things began to change when we began looking at psychiatric illness from a scientific perspective. And that was in the 1790s when some of the pioneers started using the methods employed in the study of the natural sciences to gain a better understanding of psychiatric illness. Psychiatric illness came to be regarded as a medical problem that was amenable to rehabilitation and treatment. The first psychiatric hospitals, which focused on treatment, opened in England and France, and since they started regarding people with psychiatric illness as worthy of compassion and care, a lot of the conditions improved. Some of these hospitals were located in rural areas, as it was believed that contact with nature had a healing property. Psychiatry began as a medical specialty in the 1800s. At the time, psychiatrists were known as alienists. Also in the 1800s, advances in chemistry made it possible to use medications for the first time in an attempt to manage symptoms like agitation and aggressive behaviors. These medications, including such substances as morphine and chloral hydrate, which is colloquially known as knockout drugs. These medications were very difficult to dose, dangerous, and rendered patients unconscious rather than treating their symptoms. As time went on, psychiatrists continued adopting new technologies that they developed. For instance, barbiturates soon replaced older medications. Barbiturates had the advantage of being easier to use and somewhat safer. They helped calm agitated patients, which in addition, in the 1930s, we see the first use of amphetamines in an attempt to treat depressive symptoms. Electroconvulsive therapy, or ECT, became widespread by the 1930s. ECT is still used to our day in a very modified form in the treatment of refractory depression, that is, depression that does not respond to standard treatments. However, back in the 1930s, it was used rather indiscriminately for all sorts of conditions that were not evidence-based. So the search for effective treatments accelerated in the post-World War II period with the development of promethazine. Promethazine was synthetic antihistamine, and it was the first medication that was developed with the purpose of finding something to treat anxiety. Back in this day, research methods were very informal, and psychiatrists or researchers would test the medication in a group of patients in a psychiatric ward, regardless of their diagnosis. So by doing so, they incidentally found that this medication helps help the symptoms of patients with schizophrenia, symptoms such as hallucinations, hearing voices, or seeing things, and delusions. This discovery led on to the development of additional medications for psychosis, including with the discovery of chlorpromazine, also known as fluorescein. Chlorpromazine was also found to be very effective in the treatment of agitation, and it became widely adopted in psychiatric wards for the treatment of all sorts of patients. As time went on, these discoveries spurred additional development of medications for even more psychiatric indications. The first antidepressant came out in 1951, followed by the first medication for anxiety. This medication proved to be very addictive, and in the search for safer alternatives, they developed a new class of medications known as benzodiazepines or benzos that are still used to this day in the treatment of sleep disturbances and anxiety. So a major breakthrough came in by 1955 with the introduction of imipramine. Imipramine represented a new type of antidepressant that was tested in open clinical trials. Those are trials where you choose a number of patients with a particular diagnosis and observe their symptoms rather than a hodgepodge of all sorts of psychiatric ward patients. So there was evidence to show the medication was both effective against depression, and it was much better tolerated, had fewer and milder side effects than earlier medications. This medication was also safer, and that spurred interest in developing additional medications with a similar mechanism of action. Soon enough, researchers found that they needed to improve the way in which they diagnosed and measured the severity of depression. This led to defining the core features of depression, those, that is, defining the symptoms that you tend to find across all patients with major depression, and developing measuring scales or questionnaires to assess the severity of depressive symptoms. So this led to better diagnostic methods, and in turn, these led to the realization that major depression was much more common in the general population than previously thought. So improved diagnostic methods plus the availability of safer, better tolerated medications really opened up the door to treating more people with moderate illness in the outpatient psychiatry setting. So the next major turning point came in 1987 with the introduction of, or FDA approval of fluoxetine. That's the medication otherwise known as Prozac. This medication was followed by similar medications out in the market. These medications were very significant because they were much safer than older medications. They did not cause cardiac toxicity or seizures and overdose, and the side effects were much milder and better tolerated. In addition, they were a lot easier to prescribe and manage. Therefore, they became quickly embraced by primary care providers. This was extremely important because it made treatment for psychiatric illness much more acceptable to a larger number of people, and it increased access. Not everybody has access to a psychiatric specialist. So further research in the 1990s gave us a new class of medications known as atypical antipsychotics. Atypical antipsychotics were originally developed for the treatment of schizophrenia, but were actually found to be effective in bipolar disorder, depression, and anxiety. So They're used to this date, and most people who are taking these medications do not have schizophrenia or symptoms of psychosis. So maybe they're due for a change of name. These developments led to medication becoming the mainstay of treatment. On the positive side, this helped treatment become more accessible to a greater number of people with a wider variety of diagnoses. On the other side, medications do not address the needs of every single patient with psychiatric illness. A lot of patients still need additional therapies, supportive services, and better tolerated and more effective treatments. So let me go back to the next slide. All right. So, all right, I was trying to get back to the,
I think just refer to the notes.
okay, so we'll just refer to the notes. We're on slide number 10. So, research has also helped us understand the biology of psychiatric illness. Prior to the 1950s, it was believed that brain cells communicated by electrical impulses. We learned a great deal about how things really work by studying the effects of psychiatric medications. For instance, there was a medication called reserpine, which was found to deplete neurotransmitters like serotonin and norepinephrine in brain cells. Reserpine also happened to cause depression in patients. This led to the development of the monoamine neurotransmitter hypothesis of depression, and gave us an insight on the way in which brain cells really communicate, which is by the means of neurotransmitters, which are chemicals. Even though this hypothesis was later found to be an oversimplification, it was a theoretical framework for the development of additional medications that turned out to be very useful. Research has changed how we understand and treat psychiatric illness. In the earlier part of the 20th century, it was common for physicians to blame the mothers of patients with schizophrenia for causing their children's symptoms, because it was believed that a certain style of parenting, where the mothers were somewhat aloof and distant, for some reason caused this development of schizophrenia. As we gained knowledge about the biology of schizophrenia, we come to realize that it's actually a very organic disorder. There are abnormalities in brain development that start around puberty that result in structural changes in the anatomy of the brain and a lot of symptoms and disabilities because of that. In addition to that, research has changed the way in which we treat psychiatric disorders. In the past, treatment was guided by expert opinion, consensus, and case reports, and now treatment is more evidence-based, based on research. And finally, research validated mental illness as very distinct, well-defined conditions, rather than something that was inside the patient's head, or something that they were making up. Moving on to our next slide, slide number 11. We've also seen an evolution of research methods. As I mentioned before, in the 1940s, medications were tested in a very informal way. Oftentimes, researchers would find a new compound, test it on themselves or the research staff, and then give it to a random group of patients in a psychiatric ward. Eventually, that led way to open trials where the medication was tested on a single diagnosis rather than a mishmash of patients. And finally, it led to the development of randomized clinical trials, which are the standard for testing the efficacy and safety of drugs. In randomized trials, they split the patient population into one group of patients serves as a control. This group gets either a placebo or a sham treatment, and they are compared with the treatment group who gets a real deal. The patients are assigned to each group in a random manner, like by chance, to make sure there's nothing fundamentally different about the patients in each group. And finally, neither the patients nor the researchers assessing their symptoms is told which treatment condition they're on. So a lot of drug development is runs on the randomized clinical trial design. Going back to slide number 12, and we try and get back into the presentation. It might be easier for the audience.
I'll be trying to win you. I can go there to wait for me.
Okay, I can do this. Okay.
They're good for you.
Oh, we're back in business. Thank you.
I can see that.
So the development of new drugs is a very extensive journey, and the FDA oversees every step of it. The entire process may take as long as 10 to 15 years. Medications have to pass a test for both safety and efficacy in order to make it to the next step. Only 1 out of every new 1,000 drugs ever makes it to the market during that entire process. And the first step in drug development is in vitro and animal studies. That's where we determine, or researchers who do that level of research determine whether the medication has any activity or whether it works in the target organs. The animal studies also yield some information about safety. If the medication is deemed to be safe enough, then we go on to phase 1 testing, which is a testing in which we give the medication to a group of healthy human volunteers. These people do not have a disease. They are just in the study to give us some more information about how the medication works with human metabolism, how the human body breaks down and absorbs medications, and also additional information about safety. If the phase 1s are satisfactory, then we may start testing the medication on people with a particular disease to see if the investigational drug is effective and also safe. If the medication, the results from phase 2 trials show the medication is still safe, relatively safe and effective, then testing may expand into phase 3 trials. Those are basically larger replication studies that look a lot like phase 2s, and that you're testing the medication on a group of patients with a particular disease to see how effective it is. If the medication is proven, has enough data to show that it's both safe and efficacious, then the manufacturer gets to apply to the FDA for approval, so the medication can be sold on the market. So, the estimated cost for developing a medication from, creating the compound to bringing it to market is estimated to be around 300 million to $2.8 billion. But the process is not over yet. Once the medication hits the market, the FDA continues conducting post-marketing studies. The purpose of these is to identify any unanticipated adverse events. Sometimes if these events happen frequently enough or are significant enough, this may result in the medication getting a warning label, which alerts both prescribers and patients about additional risks. In some rare cases, if the medication causes serious adverse events, then the medication gets withdrawn from the market. As you have seen, drug development is a very complex and expensive process. This sets pharmaceuticals apart from nutritional supplements, which are not subject to this level of scrutiny to prove their safety and efficacy. Let's look into how a study is carried out. The first step in conducting a study is to draft a protocol. A protocol is a document that spells out all procedures involved in a study. It has to be drafted in accordance to the rules and regulations governing clinical research. Protocol prior to implementation has to be reviewed by an independent board of reviewers called an IRB or Institutional Review Board. IRBs are multidisciplinary teams made out of medical professionals, statisticians, scientists, as well as lawyers and regulatory experts. Only after the IRB determines that the protocol meets regulatory criteria and that it takes satisfactory measures to protect patient safety and patient rights and the integrity of the data, we're not allowed to start the protocol or study procedures until we get FDA approval and make sure everything is satisfactory. Once approval is granted, the first step in running the study is finding study participants. Most study candidates find out about us and other studies through advertisements, but some of them come to us through word of mouth. Every single person interested in medical research has to go through an informed consent process. This is where we sit down with the participant at the initial visit and tell them about the study, the potential risks, potential benefits, and if there are any alternatives for treating their condition. The patients or participants do not sign the consent until we make sure that they understand what they're getting into, that they understand their rights, the study risks, and the responsibilities in the course of the study. If sometimes participants get assessed by means of comprehensive quiz, and once we determine that they're ready to start the study, they sign the document and they're officially in. The next procedure that usually happens in the course of the study is a very thorough medical evaluation. We do that in order to make sure that the patient does not have a medical condition or other condition where their participation in the study would pose unacceptable levels of risk to their safety. In the course of the study, we collect information, administer questionnaires, blood samples, Studies may take the participant as little as a few hours to complete, a couple hours, or as long as several months. However, participants have the right to withdraw from the study at any point in time and for whatever reason. We always tell them that they want to hurt their feelings, if they don't want to continue the study for whatever issue there is. So once all of the participants that are specified, the number of participants specified by the protocol is enrolled, and the last participant finishes the study, we get to the part that we are excited about as researchers. That is the analysis of the results with the help of a statistician. Once the results are analyzed, the report is submitted to some peer-reviewed medical or scientific journal for publication. The entire process, which starts with the drafting of the protocol and ends with publication, takes several years. So the success of the research study hinges on the work of all the members of the research team and collaboration with the study participants. The research team includes the principal investigator, who is responsible for designing the studies and overseeing the conduct of the studies. Research coordinators, who are incredibly well-organized people. They make sure that study procedures are performed according to the schedule, and that we are faithful in following the protocol to the letter. They also maintain case report files with data about the patients and regulatory documents. In addition to that, we have study clinicians who this group includes nurses and doctors. We are responsible for performing medical procedures that are part of the study. We also assess participants, make medical decisions regarding their care, and oversee safety. Study participants and psychiatric studies play a very important role, because they are the only source of information that we have about the symptoms that we're investigating. Unlike other areas of medicine, we don't have too many direct ways of measuring disease outcomes in psychiatry. The information that we get is what the patients tell us about their symptoms. For instance, other areas of medicine like oncology or cancer care have other means to determine whether an intervention or treatment was effective. They can do blood draws, they can do biopsies, do scans to see if the tumor is responding to whatever experimental treatment they're administering. We have to ask the patient about their symptoms. The way in which we do this is by means of questionnaires that have been developed and validated by research to measure psychiatric symptoms in an objective, standardized way. Only team members who have gone through a certification program are allowed to administer those questionnaires to the patients. Participants are also involved in data collection by means of completing surveys or keeping symptom diaries. Occasionally, these data collection procedures can be fairly involved, so it requires a great deal of commitment and conscientiousness on the part of the patient. So, in my experience, those people who volunteer to participate in our studies are very special people. They tend to be very insightful. They have a genuine desire to learn more about their condition and to help other people in their situation. And we in the research world are incredibly grateful to them for their contribution to making a study successful. So, as a longtime member of the research team, I have been lucky to witness some progress in the way in which psychiatric illness is treated. A good example of this is binge eating disorder. Although we've known about binge eating for a long time, and we've known that it is well-defined eating disorder, it has taken years of research for binge eating disorder to get official recognition. Official recognition as a diagnosis is very important because it facilitates advocacy, education of the public, and research into new treatments, both research for psychotherapies and medications. This crucial step forward didn't come for binge eating until 2013, when it was officially recognized as a psychiatric diagnosis in the Diagnostic Statistical Manual for Psychiatric Illness, DSM-5. In the early 2000, following this, in the early 2010s, our Chief of Research, Dr. McElroy, assumed charge of a large research program of phase 2 and phase 3 studies that was conducted nationwide. This program culminated in the FDA approval of the first ever medication for an eating disorder. And that was the first medication in history that had been approved for an eating disorder, not binge eating alone. This research program began here at the Lindner Center when Dr. McElroy designed and conducted the first pilot program of lensethamine and binge eating. We are extremely proud of having been part of this process. So, to conclude this presentation about what has research done for us, let us return to our friend Lisa. A little over a decade ago, there was very little that we could offer her in terms of treatment and accurate information and treatment options, but a lot has changed. We hope that the advances made possible by research will result in a better quality of life for people like Lisa. So, at an epilogue here, Lisa comes across the TV show segment about binge eating disorder, and for the first time in her life, understands what she's been experiencing. After many years of believing that she was weak, undisciplined, or a loser, she finally understands that she has a medical condition. She knows that binge eating is a very common eating disorder and knows that she's not alone. She's aware of the treatment options. The weight of years of shame and guilt have started to lift, and she feels hopeful. So, thank you for your time and attention. This busy time of the year. If you would like some additional information about the work that we do at the Lindner Center Research or about our current research study, here is the contact information for our wonderful research coordinators. Time for questions.
Any questions coming through virtually?
No.
And any questions here from those who have gathered? Go ahead. Yeah.
How many drugs are tried to be put through one trial? Like 30,000, 3,000? We didn't catch what you said.
Out of every 1,000 new drugs developed in a lab, only one makes it to approval.
Every 1,000?
Yeah.
Gotcha. Thank you.
Any other questions? I have a question for you. So patients come to Lindner Center from all over the world. do they ever come to you all and say, research center, help us with medications? Or do you ever find that the research we're doing helps people who come for an assessment?
Occasionally, people contact us from, the other side of the world because of, some of the disorders that we study are very rare and there's very little in the way of treatment. People contacting us from New Zealand wanting to get into our studies. Unfortunately, we do not yet have a means of including people in that situation. But,
What I found fascinating is that the people who come to Lindner Center from other parts of the world to do assessment work, the research centers there with the ability to look at some medications and say, oh, well, we've learned about something new, let's try that. Dr. McElroy really is one of the top in the world. And for those who live in Cincinnati, that's quite remarkable. So I just wanted to bring that up. You work for an incredible team. I also work at Lindner Center, so I'm very proud of what we do, but I'm very proud of what you all do in the research center.
We're very fortunate. We have a great team.
You do have a great team. I thought tonight was fascinating.
Nobody's
No, honestly, you all are very, what I love about Lindner Center, we're very, the people there are very smart and they're very kind. So thank you so much for your wisdom and your kindness tonight. If there are other questions online or from those who are gathered here tonight, we will say thank you very much. And good night to everybody from Lindner Center of Hope as we celebrate 15 years of serving the world, including Cincinnati. Thank you so much. You're welcome. Thank you.